Thank you very much, Alan. And thank you very much for the invitation to speak to the bowel section of oncology. It's certainly a bit of trepidation because I'm certainly a non-oncologist, and I wouldn't want to think that I'm sort of telling you what to do, because I fully appreciate the difficulties of implementing this type of thing within the current monster of cancer waiting times, particularly in NHS England. So the reason why I'm here is I was involved in what was Making Good Decisions in Collaboration programme, the MAGIC programme, which Richard Thompson led. And I was one of the clinician implementers in trying to get it established within a large hospital organisation, which was the Newcastle Trust. So how do you go about it? Well, the first thing is, as has previously been emphasised by Richard and Belinda, and certainly Alan as well, is to acknowledge that it's needed. And there's, no doubt that things are changing. The previous paternalistic care model, doctor knows best type of model, is certainly completely outdated, and I think, most people would agree with that, but we still sometimes lapse into it, particularly when we face with a person who it's a bit more challenging to get involved. The other thing we've found in the MAGIC programme, it certainly needs strong senior clinical leadership and also managerial leadership to implement it. The other thing is, I'm sure you've been hearing about at this conference, is that the options of treating diseases, and prostate cancer is a prime example, are expanding. So every stage or patient stage within prostate cancer, there are a number of options that they've got to choose to, together with their advisors, to plan the way forward. The other thing about involving patients is, we're probably galloping towards an area of resource rationing. So again, that's something, we're not going to be able to offer everything to everybody. So involving patients in decisions about their care is very important. Sometimes it's part of targets, so we've got a decision-making target in our commissioning groups in Newcastle. And the other thing is, once you get going with it, it actually makes your life a bit easier. So the patient's engaged, they've got a stake in what happens to them. If the decision is in line with what they think's best for them, then they can cope with the complications of the outcome, like Alan has clearly demonstrated. And then obviously when things do go well, which obviously most of the time they do, then you can share the joy. So how to go about it? So we've heard one model, and there are a number of models of how to go about this. So as Belinda was saying, one way is to not to do it yourself at all. So basically, have a decision coach. So as she's been expanding, what you have is a diagnosis, a patient with a diagnosis. They get sent some support material or have a phone conversation with a supporter or a coach. And then they have a consultation, not with a clinician, but with a coach to help them decide what's best for them in the light of the evidence that they've been provided. And then us, the clinicians, are just a technician. So, the one who was sent to you for a radical prostatectomy, you do a radical prostatectomy. Another group will be sent to the radiotherapist or the oncologist, for example. So that is certainly one method. But as Belinda and Alan have said, pretty difficult in the NHS to free up some resources from elsewhere to employ decision coaching is practiced in San Francisco and Dartmouth in Massachusetts. Another way is to get somebody else to do it. So this is a model that rather by default we did slightly end up with in the decision support we've done, which is in benign prostatic treatment of male LUTs, where you can get somebody else to do it, either the general practitioner in the UK or a nurse practitioner, because there's a feeling that they may have a bit more time to deliver the information given and elicit the patient's values and preferences, which is a key part of shared decision making. And then really they make the decision, and then they come to you just to check that it is in line with their clinical findings, and then you go ahead more as a sort of top layer, if you like, in terms of carrying out that chosen decision. But probably more likely, and I think really this is the option that we really should think about going for, is where the actual person who carries out the decision, the clinician, in terms of carrying out the treatment, is involved in the decision making. But unfortunately, inevitably, it does take a bit more time, and probably it does take at least 2 consultations. So you really need one sort of scene setting, like Richard has described, about outlining the choices and their benefits and risks, and then a second consultation, which needn't be face-to-face, it could be telephone, where the patient makes a decision and then they're then directed to the provider of that option. So it is a matter of, first of all, choosing which type of approach you're going to go for. So the next step, as Richard again mentioned, is training is very important. So we all feel that we do engage our patients and we talk to them and we try and get a feeling of what they feel would be best for them. But certainly it was eye-opening for me to go to training, and one of my colleagues in reconstructive surgery has recently gone to the training, and he went with an attitude, "Oh, I already do this, what's the point?" And he came back and said, yeah, it really made him think that actually you can go a bit further, particularly about finding out what the patient's really thinking about the evidence you're presenting them, about the options and which decision to make. And, although that is just a cartoon, I mean, you do see it in action from time to time. So really it's about using some skills, particularly active listening and acknowledging that there are 2 experts in a consultation. The patient's obviously got a lot of expertise in what's right for them. And this is perhaps the hardest part, is trying to encourage some patients to actually engage and take part, because, sometimes you do, repeatedly ask, well, what would you do, doctor? And it's trying to sort of challenge that to help them to, maybe think a bit deeper, particularly these in very important decisions. So the next thing is to choose a decision that you want to try and show that you're sharing the decision with the patients. And as I say, for the MAGIC program, we chose male LUTs, and we used the NHS decision aid, which was already trialled and validated. And after some initial teething problems and having to change the pathway, we actually were very successful. Well, not me, but our nurse practitioner team were very successful at implementing it, although they did have to change their pathway, so they had to add in an extra telephone conversation to confirm the decision that had been discussed at the original face-to-face consultation. And that was quite an easy win, and then we've moved on to some more difficult ones. So it's probably best to choose an easy one to practice with your patients, so to speak, and then move on to some more tricky ones. So there's a few examples, and maybe Professor Klotz talk shortly. Maybe that's one area where it'd be fairly straightforward to have a look at the benefits and harms of intermittent versus continuous androgen blockade. And then, although it's not essential, you can keep these facts in the head. People do like a bit of information, either in written form or access to internet resources, of which there's several good quality ones. So you do need some information on the relative benefits and harms of the particular treatment choices. But added to that, what you really do need is a way that patients can actually identify what their values and preferences are related to that particular decisions. It's things like, how would you tolerate erectile dysfunction following radical prostatectomy, for example? Would that be acceptable, accompanied by cancer cure? So the next step, unfortunately, is to have a meeting. So meetings, they're obviously difficult things to have, to get everybody in the same room. And often it's a bit difficult to get everybody agreed on some action points at the end of it. But I think meetings are essential, and it's because you've got to get everybody involved. You've got to get managers involved, because you might have to change the pathways, which are always set in stone. The manager always throw up their hands in horror and worry about the cancer targets. Probably a good idea to try and get a patient voice as well, because things that seem okay to you, might not seem all right or very convenient for the patient. Oops. And get some at least consensus to agree to try it. And again, to emphasize that, very important to get everybody going to some simple training to show what their decision making means and how to implement it. And one of the key things, as I've emphasised, is you've got to think of ways of how to get that particular patient group engaged into what you're trying to do. And Richard already mentioned one way is to try and encourage people to start asking questions, not about their care, but what are the options and what are the risks. And it's very important, like anything, any change of planning is to plan what you need. And there are a few things there, particularly publicity about it, reminding people, both patients and clinicians, what you're trying to do, and also to think about how to measure whether it's making a difference or not. And sometimes it is difficult to keep going, particularly if there are early setbacks, somebody leaves or somebody doesn't want to do it. Got to change the pathway, a lot of argument about that. So there are setbacks, but you've got to try and keep going. And one thing people are very keen on, and this does provide some degree of help, because with revalidation, for example, we've all got to collect patient viewpoints, do patient surveys, do audits and things like that. So it is very helpful. And we found just these simple type of questions about whether patients felt that they were asked their feelings about different options. And we trialled this in a real renal stone clinic and found some quite marked differences between different clinicians in terms of how much the patients felt they were engaged in the decisions making, usually quite simple decisions that were being made. And just to reiterate Richard's point, people do get obsessed with tools, and we've found this with prostate cancer, particularly using the NHS localized prostate cancer tool, which is on the Right Choices website. People get bogged down between, difference between 4% and 5% in terms of complications and things like that. So tools, are helpful, particularly for patients, but you don't want to get bogged down in particularly the minutiae of percentage complications, things like that. And I mentioned about the need to adjust the pathway. So I think these are the sort of top tips that we found and summarise in the MAGIC programme from different, not just in urology, from obstetrics and gynecology and ENT and breast cancer. So these are the sort of things that people noticed were the top tips in terms of getting things going. So it's key to get people involved and willing to give it a go. Any information's got to be kept as short as possible. Sometimes with these option grids, you end up them so long they become a bit like a book. You need an enthusiastic leader to try and drive it all through, and you've got to be prepared to alter pathways which seem set in stone. And this is just one of those option grids that Richard was mentioning, where you put the different options along the horizontal and then get the patient to sort of mark what's important to them on the vertical scale. So I think it's got to happen sooner or later, because there are a number of imperatives that are forcing us to share these decisions more widely, to get a more engaged public and patient group, and try and reduce decision regret. And I'm very willing to share any sort of experience that we've had in urology. And there are a huge amount of resources out there. So a lot of this is internet-based. So the NHS has got a shared decision-making site. I've been through the localized prostate cancer tool. I wouldn't say it was easy. And I think I got confused at quite a few points. I forget what I selected as treatment at the end, but it's not easy, and I'd encourage you all to maybe have a go with it, to register and have a go with it. There's also a huge repository of decision aids and decision tools on this website here, which is from the Ottawa Institute. What else is there? And this is the Health Foundation who funded the MAGIC studies. So there's a lot of information there from what we learned from the implementation program for that. And that's the other big American organization involved in shared decision making at Dartmouth. So what I would say is that we're probably, you probably need to do it, particularly in these preference-sensitive decisions like treatment of localized prostate cancer. And, it's not easy. And I think particularly the comparative evidence, when there aren't randomized trials, is a very difficult thing to get across. So thank you very much.
Rob, thank you. Are there any questions or? Yes, Caroline. Is there a microphone?
A really great session. My question is about the information that you're basing your decision on. Because typically you might have perhaps smaller data sets of UK data, and they might be based on recurrence, PSA, that kind of thing, without PROMs. Or you might be looking at American data sets from kind of high-volume surgeons for radical prostatectomy. So how do you get that into your decision-making tools and get the right information to give to people?
Yeah, I think that is a tricky thing, and this is one thing we got a bit bogged down with the prostate tool, which was designed by consensus, and didn't fit with local experience or local rates. So I think that's where we've learned that don't get obsessed with the information of the tool. Prepare your own very brief information, perhaps in decision in the grids, the option grids, or in the type that Richard showed, and develop your own really that you're comfortable with. But the trouble is, for example, with localized prostate cancer, then you've got to do the same for brachytherapy or whatever. So you obviously got to be honest with patients, and I think that becomes a difficulty when you've got different clinicians with different perspectives behind each of the options, and ideally probably that's where you want a neutral decision coach, like Belinda was describing. But I would say use your own local information.
If I can come in there, that's what we do. So we audit our data and we present the patient with what they're going to receive in this hospital. Doesn't matter what they're going to get in the Mayo, it's here. And I think that's where BOS and national data collection can really help us all give our patients the local outcome data, but that's what they should be getting, really.
I agree, and I think that's Science got a role for that in registries for all surgery and
Any other questions?
Who else is doing this?
Yeah, I mean, there was an initial surge about when it was probably about 8 years ago when people were involved in formatting the decision aid for localized prostate cancer. To my knowledge, not many people are using it. We using it in one of our peripheral clinics before they see a cancer clinician. So, I don't think it's being implemented widely. The funding for the actual paper booklets and accompanying CDs is now finished. So the only way you can access it is through the website. But I think I'd encourage people to have a look at the website, register it, and go through the tool and see if it's right for their patients, because it's pretty good, but it's hard work. It takes about an hour to go through it. So.
There's another question. Could you give us your name and institution?
Yeah, sure. Richard Robinson, Manchester. I'm obviously in urology. We've got a lot of patients who have chronic disease in terms of patients on active surveillance for prostate cancer or small renal masses. And I'm just wondering how this process, because this is very much a sort of initial diagnosis and decision making, how this process follows through, because each subsequent consultation with those patients involves another decision. Do they continue with surveillance? Do they opt for active treatment? So I'm just wondering how this runs through that process.
Yeah, I think that is tricky. I guess you need a sense. The clinician needs obviously to hold a sense of what that patient's trajectory, if you like, is going to be, and then at particular points bring up the decisions that have to be made. About rebiopsy, I guess, about frequency of PSA checks. Anything that there is a choice involved, then ideally, you need to share that choice. But, it becomes very hard in follow-up, when you're, traditionally, you've got 5 minutes or 10 minutes with a patient to actually go through a list. And maybe that's where the pre-arming patients, like has been started to do in diabetes, where have a patient-held record and get their blood test results before they come. People might, as I think does happen in some places, know their PSA result before they come to the consultation. But added to that, what the implications are in terms of having to make a new decision about rebiopsy or whatever. But I agree, it's difficult. And that's why I think when you're starting out, is pick an easy one. you know, and then once you've trained in it, then sometimes then it does become more straightforward, I guess.
I think it's a good question, and what I would do with those patients is set thresholds that trigger treatment, you know, agree those at the outset. The caveat to that is as Groupman and Hartspan point out in their book, is that you will perhaps change your thought processes 4 years down the line. So you have to be prepared to shift with the patient and accept that, well, treatment might change, their opinions might change. But, you know, it's easier at the outset you say, well, this is the threshold which triggers treatment for you, be it a partial nephrectomy or a biopsy or whatever.
Can I add something
sorry.
to that?
Yeah, it is working.
Yeah,
it is.
yeah, well,
Is it working?
Yeah, it is.
Okay.
It is.
We found that when patients were more knowledgeable about their condition, and often they did have multiple conditions, they tended to be more conservative about their decision making. And there seemed to be a follow-up effect. So if people have started by being more informed and more engaged in the decision-making process at the beginning, then again that was sustained over time. And they seem to be more satisfied as a result of that engagement.
yeah, and I would add that it's important to keep a record of the patient's values that made them make the active surveillance decision, and then take them back to those values and say, does that still hold, or do you think your situation's changed? Do you know, want to change your decision?
Tim, one last question. Yeah.
Isn't someone inevitably going to be happy with a conservative decision in the short term? I mean, that's my problem with this, that you're bound to be happier with a conservative decision in the short term, because the problems with a conservative decision are in the long term. The problems with the treatment are in the short term. Isn't that the situation?
Belinda, you were shaking your head a bit.
I was following people up for 6 months at that point.
Well, that's a short term.
So you were talking about that short term.
Well, it is.
I think,
I wouldn't say that is necessarily the case, because you can look at other studies and find that in fact when you align people's decisions with what is important to them, and if that's conservative management, then that's the sustained over time. People will change their decisions.
Thank you. I think we'll draw the discussion to a close. Can I thank all of our speakers, Richard, Belinda and Rob, for excellent contributions.